everyone. The next module is abnormal head size in children. Now, abnormal head size, that is microcephaly, macrocephaly and their associated disorders, is a topic which begins from general pediatrics and goes all the way deeper into the realms of neurology. The fine points of hydrocephalus, the fine points like posterior fossa malformations and neuroregression syndromes have been discussed in the neurology segment by the subject expert. Here we shall be restricting ourselves to discussing the general pediatric aspects of abnormal head sizes in children. How do we define them? What are the points which are relevant and asked in NEET super specialty exam? So let us begin the discussion. The first thing we need to discuss is a topic known as macrocephaly. What exactly is macrocephaly? To define micro and macrocephaly, we always take the head circumference or occipitofrontal circumference and then we plot it on age appropriate charts and see where does the head circumference for age lie. Macrocephaly is defined as head circumference or occipitofrontal circumference more than +2 standard deviations of the mean for that age and sex. So if it is more than +2 standard deviation, we call it as macrocephaly. Some of the Western countries, including United States of America, take percentiles into play and there they define it as equal to or more than 98th percentile according to the charts. WHO as well as the standards we follow in India, most of the macrocephaly based charts, we take more than +2 standard deviation as the traditional or standard definition. So macrocephaly is more than +2 standard deviation. Now, other than this +2 standard deviation, sometimes what may happen is a child comes early to you and you may not be able to identify macrocephaly because the head circumference is increasing. Now, if you have seen the charts, you would find that these centile curves, the standard deviation curves, they are sometimes, as in a younger child, they are very close to each other. And so we should have another marker for macrocephaly. So a potential MCQ can be asked, what is a early marker of macrocephaly? The early marker for macrocephaly is increase in head circumference by more than 2 cm per month in the first 6 months of life is also indicative of developing macrocephaly. So if either this is present or this is present, we assume the child and we investigate on the lines of macrocephaly. So first is how you define macrocephaly. Next we come to the common causes of macrocephaly. The common causes, first of all, we can define as megalencephaly. What is megalencephaly? Megalencephaly means enlarged brain size. Megalencephaly can be due to benign familial causes, which is the most common cause of megalencephaly. It can be seen in neurocutaneous syndromes like neurofibromatosis, tuberous sclerosis and Sturge-Weber syndrome. It can occur in Sotos syndrome. It can occur in Fragile X syndrome. Remember that Fragile X syndrome, children are mentally retarded, but they have large ear, large testes and large brain as well. It can be seen in leukodystrophies like Alexander and Canavan disease. Canavan disease, you can mark, it is an old MCQ already asked. And it can occur in storage disorders like Tay-Sachs disease, mucopolysaccharidosis and GM1 gangliosidosis. So the first group of causes is megalencephaly, where the volume of the underlying brain, the size of the brain tissue itself is large. So the head is large in size. Second, you have hydrocephalus, which is due to raised CSF volume. Hydrocephalus, increased ventricular size due to increased CSF volume is hydrocephalus. Then it can occur due to thickened cranium as seen in conditions like achondroplasia, thalassemia major, osteogenesis imperfecta and osteopetrosis, also called as marble bone disease. It can occur due to enlarged vascular compartments like arteriovenous malformation or hemorrhages like extradural, subdural, subarachnoid or intraventricular hemorrhage. It can occur due to any intracranial space occupying lesion like a cyst, mass, abscess or brain tumors. It can occur due to a condition called as pseudotumor cerebri. It can occur due to chronic lead poisoning. It can occur due to hypervitaminosis A. And finally, galactosemia. In some long-standing cases, you may find macrocephaly. All of the following can lead to macrocephaly except. This is how questions can be asked in super specialty, and so the list is important. If you try to Google, if you try to go into other textbooks, you may find even bigger list, 2 times, 3 times this list. This list is based upon what are important points, and it is based upon Nelson 21st edition. So these are the bare minimum, not the maximum, bare minimum things you need to remember. Now, what are the additional MCQ points you need to know? What is Miguel-Kefli? As I said, Miguel-Kefli is increased brain tissue mass, but there is a proper definition to this. Miguel-Kefli is an anatomic disorder of brain growth where the brain weight to volume ratio is more than 98th percentile for age or more than 2 standard deviation above the mean. So the weight volume ratio for the brain, if it is more than +2 standard deviation along with macrocephaly, we call it as Miguel-Kefli. Basically, the brain tissue itself is bigger, larger, heavier as compared to normal children. Bigger tissue, bigger brain does not mean intelligent person. So Miguel-Kefli again has got no relation with, in fact, some of these children ironically are found to be having low IQ and intellectual dysfunction as well. So most common cause of Miguel-Kefli mentioned in Nelson 21st edition, benign familial Miguel-Kefli, potential MCQ. Another important syndromic cause is Sotos syndrome. So these are the MCQ points related to macrocephaly. Next we come to microcephaly. Now what is microcephaly? Microcephaly is defined as head circumference or occipitofrontal circumference below -3 standard deviations of the mean for age as well as sex, that is gender. So macro is more than +2, micro is less than -3. This is a small thing where people go wrong, small important thing. So micro is below -3 standard deviation of the mean. Microcephaly, according to Nelson, is divided into 2 parts. We can have primary microcephaly, which occurs due to genetic syndromes. It is also called as genetic microcephaly. And second is secondary microcephaly, which is usually due to non-genetic causes. The secondary cause can further be divided into 2 parts. Although this classification is controversial and not followed, but you never know which examiner is framing your MCQs, so you need to know about what is there in the literature. So secondary can further be divided into 2 parts. One is the congenital microcephaly and second is acquired microcephaly. Congenital is the one which will either be present at birth or will present within 3 to 4 weeks of birth. That is, they will present in the neonatal period. Whereas acquired microcephaly is the one which will usually present late in infancy and sometimes in childhood as well. So a typical example of acquired microcephaly, as we will see, is Rett syndrome. So this is the classification for microcephaly that you need to remember. People get confused between primary causes and congenital causes. This is not the classification. Classification is simple. Primary is genetic. Secondary is non-genetic. Among genetic, that is secondary causes, you can have congenital causes. And congenital does not mean on day 1. Congenital here means within 3 to 4 weeks, and acquired are the ones which manifest beyond the neonatal period. So this is the definition for microcephaly. Next we move to the common causes of microcephaly. The list for causes of microcephaly is 2 times that of macrocephaly. So we'll take the help of some mnemonics here and we'll try to do it in a systematic, restricted manner. First of all, primary causes, that is genetic causes of microcephaly. It can be given by the mnemonic, why Dr. Russell Peter can't see ejection fraction in child. Stupid mnemonic, but always works. I've been using this mnemonic since quite some time now. So what do these keywords mean here? W stands for Williams syndrome. D stands for Down syndrome. R stands for Rubinstein-Tybee syndrome. P stands for Patau syndrome. C stands for Cry-Do-Cat syndrome, which is also known as chromosome 5 deletion syndrome. Then S stands for Smith-Lemli-Opitz syndrome. E stands for Edward syndrome. F stands for familial microcephaly. Otherwise no problem is there, but due to genetic reasons, every person in the family has head circumference less than -3 standard deviation. And finally we have C, which stands for Cornelia De Lange syndrome. So these are the common important genetic causes of microcephaly. Next, we move to the secondary causes. The secondary causes includes congenital infections like congenital CMV, congenital rubella, congenital toxoplasmosis, and Zika virus. Zika virus is a hot trending topic because congenital Zika virus infection is one of the common causes of microcephaly, as you can see worldwide. The disease has been known since 1950s, but it frequently causes epidemics and sometimes pandemics, restricted pandemics every few years. The current one started in Brazil and Argentina and Chile, and it is currently still ongoing, although India fortunately has been relatively unaffected from this particular infection. Another point to remember is toxoplasma. Congenital toxoplasmosis can have either a large head, that is hydrocephalus, or it can have a small head, that is microcephaly. So remember that most congenital infections, if they affect brain, they tend to produce microcephaly. If they affect, if they don't affect, fine. If they affect, they produce microcephaly. Toxoplasma is unique that it can cause either microcephaly or hydrocephalus. So when you talk about causes of hydrocephalus and congenital infection, then also toxoplasmosis will come there as one of the causes. But here it is mentioned as one of the causes of microcephaly. Next, we have maternal causes like maternal alcohol, maternal smoking, maternal radiation, maternal phenytoin, and maternal phenylketonuria. Then infections in infancy, meningitis and encephalitis can cause microcephaly. Perinatal asphyxia and uncorrected hypoglycemia can cause microcephaly. Protein energy malnutrition can cause microcephaly. And then you have important acquired causes. Many of these causes which I mentioned earlier can be acquired or congenital, but this is purely acquired microcephaly which are asked in MCQ entrance exam. So I've mentioned them separately. You can remember the mnemonic RAS. R stands for Rett syndrome, A stands for Angelman syndrome, and S stands for Seckel syndrome. These are the three important causes of acquired microcephaly, where at birth the head circumference is normal. Till 4, 6, 8 weeks of life, the head circumference is usually normal, and later on you find that the head circumference tends to fall below -3 standard deviation. So these are the common causes of microcephaly. Now the MCQ point. Which neural cells are affected by Zika virus leading to microcephaly? By itself, it is a huge topic which has been dealt separately. But remember that Zika virus has a tendency to initially affect, first you know that it is transmitted through the bite of mosquito to the mother. It crosses the placental cells, causes infection in the Hofbauer cells of placenta, which are lymphohistiocytic cells in placenta, and from there it reaches the fetus. In the fetus, it affects the neural progenitor cells, especially primitive glial cells, that is primitive astroglial cells. Astroglia are not only the connective tissue substance of the brain, they are also involved in development of neurons. And because these primitive glial cells are affected, it leads to decreased neuronal differentiation and produces microcephaly. This is a very simplistic way of explaining. There are many molecules and processes involved here, but from entrance point of view, these are the key words that you need to remember. So primitive glial cells are the chief cells which are affected in Zika virus, which produces microcephaly. Now let us talk about a conceptual approach to neonatal skull and some of the MCQ points related to that. This is a normal skull of a newborn. The things to highlight: this is your anterior, we are seeing from the top, and this is your posterior. Now you have this metopic suture in the front, which is also called as frontal suture. Then you have two lateral coronal sutures anteriorly. In the midline you have sagittal suture, and posteriorly you have two lambdoid sutures. These are the major sutures that you need to remember. The diamond shaped space which is present anteriorly is called as anterior fontanelle, and the small triangular space posteriorly is called as posterior fontanelle. So what to know for super specialty exams regarding the anterior fontanelle? Now anterior fontanelle, what is the normal size at birth? The normal size at birth is approximately 2 centimeter by 2 centimeter in a term child. In a preterm child, it may be as big as 3 to 3.5 centimeter by 3.5 centimeter, but that is for preterm babies. So in a normal anterior fontanelle, some books say 2.5 to 2.5, some say 2 by 2, Nelson says 2 by 2, so we are taking 2 by 2. Anterior fontanelle, what are the sutures which contribute to formation of anterior fontanelle? So there are three sutures. One is your sagittal suture, second is coronal suture, and third is metopic or frontal suture. MCQ point. All of the following sutures are involved in formation of anterior fontanelle except the fourth option was lambdoid suture, and that was your answer by exclusion. If you look at the syllabus of super specialty, many questions will be asked from applied anatomy and physiology of pediatrics as well, and this is a typical example of applied anatomy related to fetal skull. It has practical implication. So sutures contributing to formation of anterior fontanelle. Normal anterior fontanelle shape, it is a diamond shaped space. So it is diamond shaped. And all of you are pediatricians, you already know that when you measure the shape of anterior fontanelle, you don't measure it from edge to edge, you measure it like this. This is how you measure it. So the shape of is diamond shaped, then it is at birth in a normal child. It is level and may slightly bulge when the child is crying. That is considered to be a normal variation. What is the normal closure time for anterior fontanelle? The normal closure time is 12 to 18 months. If you have to choose a single value, the answer is 18 months. So that is the normal closure time for anterior fontanelle. Let us talk about some abnormalities related to anterior fontanelle. What is important for your exams? What are the causes of delayed closure of anterior fontanelle? If it is not closing properly, many times the causes are idiopathic. We'll only write the major causes. Secondly, if the underlying pressure is high, it will not close immediately, it may take time. So that is hydrocephalus. If thyroxine is not there, hypothyroidism, that can cause. For closure, sutures have to come and approximate. Bone should grow. If bone is not growing, that can cause delayed closure. So rickets. It can occur in other bony disorders like osteogenesis imperfecta and hyperphosphatasia. It can also occur in protein energy malnutrition. And finally, it can occur in heavy metal poisoning. So these are the major causes. There is a long list, but these are the major causes from entrance point of view, the bare minimum that you should know. Then cause of premature closure of anterior fontanelle. Premature closure is produced by a group of condition called as craniosynostosis. We'll discuss this topic separately. Then you have causes of bulging anterior fontanelle. Anything which raises the intracranial pressure will cause it to bulge. Transient bulging can be seen in crying, but that is normal. Persistent bulging can be seen in conditions like hydrocephalus, arteriovenous malformations. Example, vein of Galen malformation, where bulging anterior fontanelle will be associated with a bruit. It can be seen in CNS infections. It can be seen in kernicterus, and it can be seen in CNS hemorrhage. And then you have depressed anterior fontanelle. Depressed anterior fontanelle is seen in dehydration in infants. So these are the major things that can be asked in entrance exam. Although not frequently asked, but you can remember that posterior fontanelle, the normal closure time is 0 to 2 months. 0 to 2 months means it is either closed at birth or closes within 2 months, that is 8 weeks of birth. Any persistent closure beyond 2 months, that is beyond 8 weeks, will be considered abnormal. There are two major causes of delayed closure of posterior fontanelle. Delayed closure of posterior fontanelle can be seen in hydrocephalus as well as in congenital hypothyroidism. So these are the only things which can be asked from posterior fontanelle. So moving over, let us talk about craniosynostosis. First, we need to understand what is the normal suture fusion time. Interestingly, two MCQs have been asked in super specialty based past exams, one of them being a Central Institute exams. So, metopic suture, when does the fusion begins? It begins at 2 months of age. The sagittal, coronal and lambdoid suture, the normal suture fusion time is 22 to 26 months of age. And the frontonasal and frontozygomatic are the last ones to fuse in a child, that is 68 to 72 months of age. So metopic suture closure, when does it begin, and frontonasal suture, when does it begin, are the old MCQs which have been asked. So you need to remember that for your entrance exam. Moving over to the definition of craniosynostosis. What exactly is craniosynostosis? Premature fusion before the average time for that suture, if it closes, that is called as craniosynostosis. So one or more skull sutures, if they fuse before their normal fusure time, that is craniosynostosis. Name itself is a craniosynostosis. Cranial bone or suture getting fused, syn means fusion, before time. It is called as primary when the pathology is in the skull bones, and it is called secondary when the damage is in the underlying brain which fails to grow, and so the bone closure is premature owing to the brain damage. It most commonly affects which part of skull suture? Sagittal suture. That is your MCQ point asked in NEET super specialty. So most commonly it affects sagittal suture. What are the causes of craniosynostosis? 80 to 90% cases, interestingly, are found to be idiopathic, that is, no cause can be found, whereas 10 to 20% cases are found to be syndromic. What are the important syndromes for which can cause craniosynostosis? If you look at Nelson, there is a one-page list of the syndromes. We need to remember just 6 or 7 of them. So these are the common syndromes associated with craniosynostosis. First, you have the Apert syndrome. Then you have Antler-Bixler syndrome. Third, you have Cruzon syndrome. Fourth is Carpenter syndrome. Fifth is Muenke syndrome. Next, you have Pfeiffer syndrome, Seythre-Schwarzen syndrome, also called as simply Schwarzen syndrome, and Schrappinson-Goldberg syndrome. I know you have read about these. Many of you might have seen cases of these as well. But for entrance exam, you have so much to read. You may sometimes get overwhelmed thinking, how would I remember all of these? It's okay. Number one, you're a pediatrician, you have seen all these cases, so don't worry. And secondly, if you have read and listened to this discussion multiple number of times, what it will ensure is, when you sit in the exam, option will be written there. You don't have to write the spelling of Schrappinson syndrome. It will already be written there. If you have read it and understood it multiple number of times, it will be easy for you to identify and mark in the paper. So these are the common syndromes with craniosynostosis. Now, what does Nelson 21st edition and various journals say? They say that many cases of craniosynostosis, especially the syndromic forms, the 10 to 20%, they are associated with mutations in FGFR gene mutation. What is FGFR? FGFR stands for fibroblast growth factor receptors. There are many types of FGFR genes. FGFR1 and FGFR2 are implicated in almost 60 to 70% cases of syndromic craniosynostosis. Of course, there are others also. FGFR3 is also there, 7 is also there, and so on. But these are the two which are important that you need to remember. Now, what are the types of craniosynostosis? It depends upon the suture variety. So there is a small ready table which I have made here. So the first one is sagittal suture. Sagittal suture, the abnormality, it's not a genetic abnormality, it is the abnormality produced, or the type of craniosynostosis produced, is called as scaphocephaly or dolichocephaly. Scaphocephaly refers to boat-shaped skull. Dolichocephaly is called as doll-like skull. Sagittal suture involvement is the most common form. So scaphocephaly or dolichocephaly is considered to be the most common type of craniosynostosis. In NEET super specialty, this question was asked in two ways. In one of the exam, they said, what is the most common suture involved in craniosynostosis? The answer was sagittal suture. In 2019, they modified it. They said, which is the type of craniosynostosis most commonly seen in children? The answer was scaphocephaly because it involved the sagittal suture. Another thing, 2 or 3 points about each variety I'll be mentioning, which can be additional MCQs in statement-based exams. So scaphocephaly or dolichocephaly, remember, it is more common in males as compared to females. And in these children, the antero-posterior diameter is increased, whereas the biparietal diameter is decreased. So they have a elongated kind of skull. So antero-posterior means like this part is increased. BPD decreased means यहाँ से it has been compressed, chapta ho gaya hai. It has been depressed like this, like you see in those cartoon movies, Tom and Jerry, where Jerry bangs a door and his head gets compressed like this. So that is typical sagittal suture induced craniosynostosis. Second variety is your coronal suture. When coronal suture is involved, the abnormality seen is plagiocephaly, which is also called as frontal plagiocephaly. And if it is bilateral coronal suture fusion, it produces brachycephaly in the patient. Coronal suture involvement is said to be the second most common variety of craniosynostosis. Brachycephaly is typically seen in children with Down syndrome. So potential MCQ, Down syndrome has which type of craniosynostosis? Bilateral coronal fusion involvement, and that produces brachycephalic. It is opposite of what you see in sagittal suture. Here you have the biparietal diameter being elevated and less antero-posterior diameter. So coronal suture involvement will cause, on one side you can write, if it is unilateral on one side, if it is bilateral on both sides, so antero-posterior diameter will be less and biparietal diameter will be more. And coronal suture involvement is more common in females as compared to males. I'm trying to sneak in as much information as possible rather than just giving you bland tables. Third is your lambdoid suture involvement. Lambdoid suture, if it is unilateral, lambdoid is present posteriorly, so it will cause occipital plagiocephaly. Bilateral, it will cause posterior brachycephaly. Then you have metopic or frontal suture involvement, which produces a triangular skull, also called as trigonocephaly. So the shape of the skull is something like this. And metopic or frontal suture is associated with various chromosomal abnormalities. Then you have multiple sutures being involved. There are two patterns when multiple suture fusion happens. The first pattern is oxycephaly or turicephaly, which is also called as tower skull. And second is Klebat shadow deformity, which is also called as cloverleaf skull or trilobular skull. दोनों नहीं होते हैं, one out of this or this. One out of these two is seen when multiple sutures tend to fuse. Important point to remember, in all of these patterns, when multiple sutures are fusing, there is a risk of increased ICP and hydrocephalus. And they are the ones which will ultimately require neurosurgical evaluation in most cases. Sagittal and coronal usually do not have raised ICP unless they have associated abnormality. By themselves, they do not cause hydrocephalus. But multiple suture fusion by themselves can cause hydrocephalus or raised intracranial pressure. So these are the types of craniosynostosis along with the MCQ points that you need to remember. Now, what is the role of surgery in craniosynostosis? The role of surgery is very limited. only a limited cosmetic surgery, that too in later life, which is plus minus, may be needed in the common forms like your sagittal or coronal fusion varieties. Whereas in those having multiple suture involvement, you may need to perform neurosurgery, which may not only be in the form of corrective surgery, but may also require placement of shunts, that is VP shunt for hydrocephalus. And many times VP shunt itself is not enough, and you may have to go in for decompressive craniectomy in many of these children, and the outcome is not that great. So the role of surgery is limited. It is in milder forms, it is indicated only for cosmetic indication, and that too is plus minus. Important differential diagnosis of these craniosynostosis is a condition known as deformational plagiocephaly, also called as positional plagiocephaly. See, plagiocephaly, you had frontal plagiocephaly, asymmetric skull frontally, you have occipital plagiocephaly, which is posteriorly, and then you have deformational. Deformational is not a true craniosynostosis. It is a positional change when the child lies on a certain position and there is abnormal molting of the skull bones. So the development of cranial flattening and asymmetry in infant due to extrinsic forces like consistently sleeping on the same side is deformational plagiocephaly. In practice, you would often find parents coming to you, 3-month, 4-month-old child, they will say, our child has an abnormal skull shape. If you see, you would find that that child, one side of the brain is flattened. On the same side, the hair are also relatively deficient. Otherwise, the overall examination of the child is normal. Any investigation you do, you look at development milestones, everything is fine. You ask the parents, does the child prefer lying on that side? They would say yes. And so immediately you would think of deformational plagiocephaly. There are ways you can differentiate it from craniosynostosis, which we'll discuss here, but this is a very common representation, and often craniosynostosis is misdiagnosed as deformational plagiocephaly and vice versa. So being pediatrician in clinics, this is something you should be careful about. What are the associated factors which can produce? Epidemiological studies have shown it is more common in male child, it is more common in firstborn child. If there is congenital torticollis, wry neck, so the child will keep his head towards one side, and so when he or she lies, it will be on that side, and so there will be plagiocephaly affecting flattening occurring on that part. It is more common in prematurity, it is common in developmental delay, and bottle-fed babies have a tendency for plagiocephaly. A child who is exclusively breastfed, his position during feeding on one breast or the other will be changing. But a bottle-fed baby will always be lying on one side, whichever side the child prefers, and he will always be sucking, or the mother will be putting the breast, and so he will put the head in one position persistently. It will increase the chance of plagiocephaly. How to distinguish clinically? Very important potential MCQ. Palpate. In craniosynostosis, along the suture lines, you have palpable ridges. This is very important. Whereas deformational plagiocephaly will have smooth edges and there will be no palpable ridges, because it is not occurring due to premature fusion. It is simply a abnormal molting, pressure induced change which is happening, and it is entirely reversible. So treatment is only supportive, reassure the parents, lifestyle changes, positioning changes are done. Many cases, severe cases, you may do helmet therapy. Details are beyond our discussion. So this is an important DD for craniosynostosis. And finally, we discuss some specific syndromes associated with craniosynostosis. First of all, we have the Shortzen syndrome. It is also known as Seythre-Shortzen syndrome. It is considered to be the most prevalent syndrome associated with craniosynostosis. One of the guidebooks for super specialty, they have mentioned in one of the mock test explanation there that most common syndrome associated with craniosynostosis is Cruzen syndrome. That is wrong. Nelson 21st edition as well as pre-test of Fenichel's neurology, both of them mention that Shortzen syndrome is the most prevalent syndrome among craniosynostosis related syndromes. It shows an autosomal dominant inheritance, and the gene mutation is twist1 gene mutation. So normally you have fibroblastic growth factor receptor mutations, but here it is the twist1 gene present on short arm of chromosome 7, location 21.1. The features of Shortson syndrome include craniosynostosis. Mostly we find unilateral plagiocephaly. So one-sided asymmetric flattening of the skull is seen. Along with that, there is partial syndactyly of the second and third digits. So second and third digits, there is partial fusion, not complete. So we don't call it as a mitten hand. And third, you have ptosis of the upper eyelids seen bilaterally. And finally, you have shortened fingers. So these are the features of Shortson syndrome. In general, Shortson syndrome is less dramatic as compared to other syndromes, and that is why its exact prevalence is not known. But studies have shown that despite being milder in nature, Shortson syndrome sometimes does not come to attention, but it is one of the most prevalent syndromes, less dramatic but most prevalent among craniosynostosis syndromes. Now moving to the second most common syndrome and the more popular syndrome called as Crouzon syndrome. Crouzon syndrome, as I said, it is the second most prevalent syndrome after Shortson syndrome. It also shows autosomal dominant inheritance. It shows FGFR gene mutation. So FGFR2 are more commonly seen. FGFR3 can sometimes be seen. The features of Crouzon syndrome. These children show craniosynostosis, brachycephaly is seen. So bilateral coronal suture fusion is a feature of these children, giving rise to a brachycephalic flattened skull where the biparietal diameter is high and anterior-posterior diameter is reduced, similar to the skull which you see in children with Down syndrome. They have severe proptosis. So this is a useful indicative value which craniosynostosis shows maximum proptosis. The answer is Crouzon syndrome. Third, you have strabismus of the eyes. Fourth, you have small maxilla and sometimes slight mandibular prognathism is seen. However, mandibular prognathism is mainly seen in case of adults as compared to children. So young children may not have prognathism. And they also are found to have a hooked or beaked nose. Finally, they have cervical spine abnormalities and they are associated with Chiari-1 malformations, so they may be associated with hydrocephalus. So if I have to show you a picture of a child with Crouzon syndrome, this is a child with Crouzon syndrome. There is flattened skull with significant proptosis and strabismus being present. If you see carefully, the child also has a slightly hooked nose, but the mid-face hypoplasia is not as dramatic as seen in other syndromes, as we shall see. This is another child having proptosis, having strabismus, and there is small hypoplasia, maxilla, small maxilla is seen. However, the mandibular prognathism is still not predominant in these children. Coming to the third syndrome, that is Apert syndrome. I have kept the photograph on the side so that I can explain and you can keep seeing on the sides. If you see in this child, there is complete fusion of second, third and fourth digits. So they have complete dramatic syndactyly. Along with the second thing which you can see is anti-mongoloid slant of eyes in this child. So lateral canthus is at a lower level than the medial canthus, and thirdly, the mid-face hypoplasia is also seen. The middle part of the face below the forehead, this part is also hypoplastic. This is a child with Apert syndrome. So it shows either sporadic or autosomal dominant inheritance. Sporadic is found to be more common than autosomal dominant. Apert syndrome is due to mutations involving the FGFR2 gene on 10q26, and the type of mutations are gain of function mutations. The features of Apert syndrome include brachycephaly. So the brachycephaly is common to both Crouzon and Apert syndrome. However, they are found to have facial asymmetry which is more dramatic and hypoplasia involving the mid-face. So mid-face hypoplasia is severe in patients with Apert syndrome. They have bilateral syndactyly of second, third, fourth, fifth digits, producing a complete fusion of the digits bilaterally. We call them as mitten hands. There is progressive calcification of limb ligaments, mainly involving the hands and feet, and sometimes also the cervical spine. Some of these children also show cleft or high arched palate. They show mental retardation and anti-mongoloid slant of eyes. And what is the classic triad of Apert syndrome? The classic triad originally described was craniosynostosis, mid-face hypoplasia, and bilateral syndactyly. This is a potential MCQ point for your NEET super specialty. What all of the following constitute classic triad of Apert syndrome, except the fourth option out of these will be your answer. And now Apert versus Cruzon, it is a clinical dilemma as well. Those who deal with genetics on a regular basis, they would know it. And even in MCQs, it is a dilemma. If you get a case, if you get a pictorial representation, or if you get a written description, how you are going to find whether the case in question is Apert versus Cruzon. So it is very simple. You have a child presenting to you with brachycephaly. Okay, craniosynostosis, brachycephaly present in both of them. There can be two possibilities. Every child need not have all of these. This you need to understand. If the question says the child is having significant proptosis, the child is having no mental retardation, no palate abnormalities, that is no cleft palate, no high arched palate, if there is no syndactyly and mild prognathism, you would, with or without features of hydrocephalus, your likely diagnosis will be Cruzon syndrome. It is very useful. However, if the question says the child is having syndactyly, the child is having mid-face hypoplasia, the child is having calcification of ligaments involved in hands and feet, and the child is having anti-mongoloid slant of eyes, or the child is having mental retardation or palatal abnormalities, then you would think of the diagnosis being Apert syndrome. So this is very important, not only for your clinical practice, but also from entrance point of view. Now moving over to the other syndromes, we'll only do the relevant points. Carpenter syndrome is the next one. It shows autosomal recessive inheritance, and the key features are three. There is clover leaf skull, that is Kleene-Bat shadow deformity. So they have a clover leaf skull, along with syndactyly, along with mental retardation. Then you have Pfeiffer syndrome, in which sporadic inheritance is more common than autosomal dominant inheritance. They show mutations in FGFR1 gene present on chromosome 8, and the key features include turicephaly, that is tower-like skull, along with hypertelorism, increased gap between the medial canthi of two eyes, and short, broad thumbs and toes. And finally, MCQ summary points to remember. Autosomal recessive inheritance is seen only in Carpenter syndrome among the craniosynostosis syndromes. Cruzon syndrome never shows mental retardation, cleft palate or syndactyly. It is a statement-based MCQ already asked in the past. And thirdly, mitten hands are most prominent in Apert syndrome. If that is not mentioned in the options, then Carpenter syndrome is the next option which you will mark. Other syndromes have either no syndactyly or only partial syndactyly, which may often even be missed. So this is regarding the syndromes associated with craniosynostosis.